Good afternoon and welcome. I know a lot of you on this call, but for those of you who don't know me, I'm Jim Carroll. I'm the CEO of the diaTribe Foundation. I'm wearing this uncomfortable harness because I just had shoulder surgery, so excuse my attire, but it's my pleasure to welcome you to today's online Musings discussion about this exciting new generation of diabetes medications that produce significant weight loss and the important role that nutrition and exercise continues to play as we all strive for optimal health. These medications, tirzepatide and semaglutide, but are known by most as Mounjaro and Ozempic when they're taken by people with type 2 diabetes, and Zepbound and Wegovy when they're taken for weight loss alone, are changing the way we treat and the way we talk about weight loss and obesity and diabetes. Just as a reminder, because these medications are not currently approved for use in type 1, we are only talking about type 2 diabetes today. Before we get started, a huge thank you to our sponsors for the 2024 Musing series, which makes these online opportunities free for everyone. Our gold sponsors are Abbott and Dexcom, Medtronic and Tandem. And our silver sponsors are Lilly, Novo Nordisk, and Vertex. All these companies and the people who work there are responsible for the development of groundbreaking technologies and amazing therapies that allow people with diabetes to live healthier lives, and they provide essential support to diaTribe so we can pursue our mission to improve the lives of people with diabetes. It's my great pleasure to introduce to you the moderator of today's panel, Dr. Kelly Braunel, a longtime friend of diaTribe's and professor and director emeritus of the World Food Policy Center at Duke University. Kelly used to be the professor at Yale and director of the Rudd Center for Food Policy and Obesity. I can't say enough about Kelly as a person, as an expert in public health. I will mention that he was named by Time Magazine as one of the world's 100 most influential people whose power and talent or moral example is transforming the world. So we are truly honored to have Kelly donating his time and his expertise today to lead what I think is going to be a fantastic discussion. Thank you so much, Kelly, and I'm going to hand it over to you.
Jim, thanks so much. And it's a pleasure for me to be introduced by you because I have so much respect for diaTribe and the work that you and your colleagues have done over the years. And then in addition to that, this topic is so darn important. It's really nice to be able to bring so much expertise to the people who are going to be listening in. So my own experience with this has gone through some changes. I started my career actually doing randomized trials with colleagues for treatment for obesity, but I got frustrated because the results weren't very good. People didn't lose much weight and they tended to regain what they did lose. And this was after trying lots of different approaches. And so I sort of gave up and decided that treatment and prevention and broader food policy was going to bear more fruit. So I moved on to that. But thankfully, other people in the field didn't and kept their nose to the grindstone and did the hard work over the years of testing various treatments. And they brought us to where we are today. So thank goodness for their work. I thought there would never be a drug that would produce anything like the kind of results we're seeing today. And so after decades later, there's been a really fundamental change in the way the field is addressing issues like diabetes and obesity. And there's a level of hope that really didn't exist so much before. So here come these new drugs. They're all over the news. There's something new about it almost every day. Some of what we see in the news are results of scientific reports. Other is conjecture and people's experience and things. So the question is, how do you bring all this together into a coherent picture that people can use in making decisions about their lives? And there are so many interesting questions. What are the effects of these drugs on diabetes? How much weight do people lose? And do they keep it off better than what we saw before? What are the side effects? What happens to appetite and feelings of being full? How do people feel psychologically about being on the drugs and about losing weight? There are lots of interesting changes that people experience, and it'll be nice to hear from experts about what they are. And another interesting question is whether these should be considered forever drugs, like a drug one might take for blood pressure or cholesterol or other similar things where you stay on the drug, it has its effects, and you don't want to go off the drug because the problem would return. So it'll be interesting to think about these drugs in that context. And of course, you'll have questions of your own, which we hope you'll ask. In the chat room to the right of the screen, you'll see an opportunity to ask questions. And the diaTribe folks will be curating those questions, and we'll have time to ask some of them later on and pose them to the experts. So we have an outstanding group of people to answer your questions and to address some of these fundamental issues, and it's my pleasure to introduce them. So I'll begin with Lorena Drago, who is both a registered dietitian nutritionist and a certified diabetes care and education specialist. Lorena brings to the panel her broad expertise in both these areas, as well as a deep understanding of the multicultural aspects of diabetes self-management education. Lorena, thanks so much for being with us.
Thank you very much.
So next we have Dr. John Jakizik. John is a professor at the University of Kansas Medical Center, where he leads interdisciplinary research that focuses on prevention and treatment of chronic health conditions, including obesity. He brings to the panel knowledge and expertise on impacts of physical activity on long-term health. There are few people that could rival John in his knowledge of this topic. So John, thanks so much for being with us.
I'm glad to be here, Kelly. Thanks.
And our third panelist is Dr. Lisa Neff, who's Executive Director of Global Medical Affairs for Eli Lilly and Company, and brings to the panel over 2 decades of experience as a clinician and researcher in obesity medicine, nutrition, and diabetes care as an endocrinologist. She's also the author on an important recent paper on this very topic. We'll share the link to that paper in the chat. Lisa, thanks so much for being with us.
Kelly, thanks very much. And thanks for the organizers on what will be a really important and useful conversation.
I agree. Terrific job putting this together for the diaTribe folks. So as I mentioned in the start, I don't think it's an exaggeration to say that we're experiencing a seismic shift in the way diabetes, overweight, and obesity can be treated with this new generation of medicines that produce substantial weight loss. Let's first talk about what these medicines are and how they work. So Lisa, let me begin with you. So we're primarily talking today about the medications, and Jim mentioned this in his introduction, tirzepatide and semaglutide, which are commonly known by their branded names of Mounjaro and Ozempic for people with type 2 diabetes, and Zepbound and Wegovy for when prescribed for people for weight loss, people who don't have a diagnosis of type 2 diabetes. So can you tell us how these medications work?
Absolutely. So tirzepatide activates our body's receptors for GIP and GLP-1. And these are 2 naturally occurring hormones that help to regulate our blood glucose and our appetite. Together, GIP and GLP-1 are sometimes known as incretin hormones. And so you may hear sometimes incretin-based therapies or the incretins, and GIP and GLP-1 hormones are what are being referred to here. Semaglutide activates the body's receptors for GLP-1 to help regulate blood glucose and appetite.
So thanks for that. So Lorena, I'd like to ask you about this. So you work with many patients who take these medications. How do people describe the effect on their feelings of hunger and fullness and cravings for food? I've heard people say, for example, that these medications quiet the noise. What do they mean by that?
Okay, so what I would like to just say first is that when we eat, there are 2 different feelings. One is when we eat when we are hungry. And that is that physical need for food. And the other times when we eat is when we have that appetite for food, when we have a desire to eat. And we'll experience that. It's usually driven by the desire to eat when we are watching TV and we see something that appeals, to us, or we pass a bakery and there is that delicious smell of bread, and it is stimulated by smell or even the thought of food. So when I speak with individuals or patients that have that, what they tell me is that first they have limited hunger. Or there is a reduction in hunger. But in addition to that, they also have a reduction in the appetite as well. So they do not have the craving for food or the desire to eat when there is that thought about that bread that could entice us, or when we say things like, well, there's always room for dessert, that disappears. So both the hunger and the appetite, both of those things disappear, which leads to a decrease in the consumption of food. And both of those, once they are diminished, then it leads to fewer calories, which also lead to a decrease in body weight.
You know, the fact that they're, I'm sorry to interrupt, but the fact that they're working kind of in both ways can be really helpful in this modern environment where people are just bombarded by cues to eat.
Exactly. And we not only have those cues, but also there is another part, which, as you know, Kelly, with the work that you have done many years ago that I have followed, um, is that many times our the way that we eat food is not just with hunger, but we also eat because of emotional cues. We eat when we're happy, we eat when we're sad, we eat when we are bored. So many times those are very tightly embedded. And that also seems to disappear with these medications. And those are the most difficult to detach. As a dietitian, when I ask people and they say, I was very stressed today and I started to eat just because of emotions. And now that seems to not be much of a concern with the medication, and they can focus more on other things.
Good, thanks. I mean, it's really nice to hear that these drugs are affecting people in a lot of different ways. So, Lisa, let me ask you about side effects. What are the side effects of these medications, and what should people do if they experience them?
Well, so clearly different medications have different side effects, but I think we could say that in general, for medications like tirzepatide and semaglutide, the most common side effects that people report are gastrointestinal related side effects like nausea or constipation or diarrhea or vomiting. And generally, these tend to be mild or moderate in severity, and they also tend to improve over time. However, it's important if people are experiencing these symptoms that they should talk with their doctor or other healthcare professional because the doctor may have a recommendation. So, for example, there may be a dose adjustment that's recommended, or a dietary adjustment that is recommended to help improve the symptoms.
Thanks. Well, speaking of dietary strategies, Lorena, what sort of things do you recommend to people to lessen these side effects?
First of all, I just want to underscore what Lisa just said, and that is that there is the dietary component, but also the physician management strategies are very, very important. Um, I always tell the patient that the medication adjustment can either be the slower dose escalation, or also that there could be a dose reduction as well, and that can mitigate the symptoms. So nausea, for example, is one of the issues, and that can be mitigated, or they could be alleviated by some of the concerns that many times people may eat very quickly and they have to readjust how they eat. So the first thing that I do is, how long does it take you to eat? And in my past life, I worked in a bariatric surgery program. So many times Some of the advice that I would give would be the same advice that was given to persons and patients that underwent bariatric surgery, and that is to readjust how they ate. And that would be small, frequent meals throughout the day. And that would be also considering that certain foods at room temperature or cold foods may be better than hot foods when it comes to nausea. Considering that meals that are high fat may also worsen nausea symptoms. And not mixing liquids with solid foods may also help with the nausea. And some things to consider may be dry foods, such as crackers, bread, and then acidic foods may also be considered to be helpful. Easy foods like applesauce, yogurt, bananas, eating slowly, and again, don't drinking fluids with the meals may also help with some of the symptoms.
Good. It's very helpful to know that. And both you and Lisa have underscored the point that it's important for people to keep in touch with the health professionals that they're interacting with. So at the very least, they can get calibrated and understand, am I experiencing normal side effects, and should I just hang in there and wait for them to go away, or are there specific changes that should be made that would help? So that's very useful. So John, I'd like to turn our attention for a minute to physical activity. And I'm really eager to talk to you about this because you're such an expert on this. And so physical activity along with diet has very long been the centerpiece of lifestyle interventions used to help promote weight loss and maintenance of that loss. But now with medications, people might think, oh, the drugs do all the work, so why bother exercising? What are your thoughts on that?
Well, how much time do we have, Kelly? I think it's a really important question, and I'll hit on a couple of, I think, key points here. One, for individuals who are now managing their weight much better with these medications, I mean, this is, as you said, this is seismic in terms of its shift. But it's also been it's potentially a seismic shift in terms of how we think about activity and exercise as well. You know, for so long, and we were part of the groups that, you know, we found that you needed to do a lot of activity to really contribute to additional weight loss, to manage your weight, to have weight loss maintenance. Because the focus was all on how many calories can I burn. The medications are now taking care of the weight. They're helping to take care of the eating. So now we have the opportunity as in the exercise and activity space to shift our thinking away from how do I maximize the calories to how do I give people a manageable amount of recommended activity that is really there for health, not obesity treatment, not for weight management. And we can shift that focus because we now probably, and this is my guess, no longer need to start thinking about I need 250, 300 minutes of moderate to vigorous intensity activity a week. I can shift that down to a manageable amount of activity that's going to create a lot of health benefits for people and take the focus off of weight. Just like we're taking the noise off of food, we're taking the exercise focus off of weight. I think that's a critical element. I think the other critical element is, you know, there are certain things that we know from our work and others that weight loss will help with. But the things that weight loss won't help with are things that exercise will help with. The muscles are not going to get stronger with weight loss. You're just unloading them. The quality of the muscle is not going to get better with weight loss. Your cardiovascular fitness is not going to improve. We know that if anything, that is one of the single best predictors of long-term health and well-being is your fitness. So we can, again, shift the focus away from weight and onto these other things. But I think that we would be mistaken by saying, we don't need exercise anymore. We still need it because we need it for the things that weight loss won't give us. And I think that that's a critical message. And we can dig deeper into some of the body composition benefits and so on. But I think this is a critical way for us to shift our thinking.
So we'll do that digging in just a few moments. But you know what you're saying, it strikes me as being very positive in nature, because you don't have to think about doing such high levels of exercise as used to be the case. So that makes the goal line much easier to get to, which will be a big help for a lot of people. And we'll talk more about what specific sorts of physical activity are most beneficial to people. But it's really nice to hear that positive note from you about the importance of physical activity and how it might be easier to get the amount that's recommended. So we'll come back to that.
Sounds great.
So Lisa, let me ask you, so these medications, which are part of a larger class of medications, were first developed to lower blood glucose levels in people with type 2 diabetes, usually measured by hemoglobin A1C. So how successful are they with regard to diabetes management in both the short and long term?
Yeah, thanks for that question, Kelly. So just taking a step back, these medications that we're talking about today, tirzepatide and semaglutide, are on the newer side. But I think it's important to recognize that incretin-based therapies for the treatment of type 2 diabetes have been around for almost 20 years now. So we have a lot of understanding of how they work and how effective they are. And they actually work in a variety of ways to help improve blood glucose. So, for example, they help our body release insulin when our blood sugar is too high. They help improve insulin sensitivity. They can help reduce the production of glucose by our liver, and they can slow down the movement of food from our stomach, all of which may help with blood glucose control in a person with type 2 diabetes. And in terms of the trials, now, particularly speaking about tirzepatide and semaglutide, the newer incretin-based treatments, there are multiple clinical trials in patients with type 2 diabetes that really underscore and demonstrate the benefits not only for glycemic control or A1C, but also for weight reduction. And so, for example, one of these is the SURMOUNT-2 trial, which was a weight loss trial of tirzepatide in people with type 2 diabetes, and it was a 72-week trial. In that study, the average weight reduction was almost 15% with the 15 milligram dose of tirzepatide, and the A1C improvement was over 2% in that trial.
So
There's a similar.
when you mention, I'm sorry to interrupt, but when you mention 15%, you're referring to the fact people would lose 15% of their beginning body weight.
That's right. That's on average. And so, for example, the math, 10% if somebody weighs 200 pounds, then that would be, a weight loss of 30 pounds, to put it into perspective. But that's the average weight loss. That means that, individual patient results can vary, and some people will lose less and some people may lose more, but almost 15% was the average. With semaglutide,
by the way,
there's a trial too.
You're going to have to forgive me for interrupting you so much, but you're making me think of so many questions. I remember the day in our field where people got very excited about a 5% average weight loss.
Oh,
and
absolutely.
You're talking about triple that in this particular trial.
Yes, right. And in the semaglutide trial, which is called STEP 2, a 68-week trial in people with type 2 diabetes, a trial for weight reduction, the average weight loss there was almost 10%, and the A1C improvement was 1.6. So, across the board, the medications have been shown to be effective for weight and glycemic control for people with type 2 diabetes.
So Lisa, I'd like to ask both you and Lorena a question about A1Cs. So are you seeing more patients achieve A1Cs below 6.5% through the use of these medications compared to just using diet and exercise alone? Lisa, why don't you go first, and then Lorena can weigh in.
Sure. So, in clinical practice, surely this is something that we're seeing. And I can actually share that there's data to support the observations that clinicians are having with patients in the clinic every day. And so, for example, in that study that I mentioned to you, in some of the studies on tirzepatide and type 2 diabetes, over 75% of patients are achieving an A1C of 7 or less. Which is the ADA goal now for most adults with type 2 diabetes. So 75%, that's a really good number. And up to half of patients in these tirzepatide type 2 trials are achieving A1C numbers of 5.7 or less.
Well, those are pretty stunning numbers. So, Lorena, what's been your experience with this issue?
I have also seen in the patients that I have seen also very positive trends in A1C below 6.5. What I would have to say is that the medications have removed multiple roadblocks, the blocks on the road that allows them to decrease the caloric intake to achieve a healthy weight, which accompanied by exercise. And I have been emphasizing weight training to achieve the recommended A1C. However, I also want to add that as a registered dietitian and also as a diabetes educator, I also emphasize medical nutrition therapy. And we also know, and it has been documented, that medical nutrition therapy can reduce hemoglobin A1C up to 2% for people with type 2 diabetes, as well as persons with type 1 diabetes. And that is at least three visits during a period of 6 months. So we have several therapies that can assist individuals with diabetes. The medication is a great tool because of what I mentioned before, that it can help with the hunger. It can also help with the appetite and all those issues that can help. But medical nutrition therapy has also been proven as a great tool to do it. So I think that having various tools is extremely important.
All right, thanks so
Kelly,
much.
can I interject something here? I want to just say that I really appreciate what Lorena is saying. And, the medications and obesity treatment in general is really meant to be a comprehensive, multidisciplinary approach. And so the role of the dietitian and an exercise specialist, and in some cases, psychologist or social worker, is so valuable for patients who are working on their weight. It really is important. I also want to just, I think some of the talk that we've just had around achieving A1Cs of less than 5.7 or less than 6.5, one caveat I would say is that, for some patients, particularly those who are on insulin or sulfonylureas for their type 2 diabetes, they will really have to work closely with their doctor to make sure that they don't have an increase in hypoglycemia, particularly when the A1C is lower like that. So.
Okay, thanks. That's a very helpful additional note. Well, the points come through over and again about the importance of keeping close contact with the medical professionals that are involved in overall care. And that would include, obviously, the physician, but also the other folks that we've spoken about as well. So thanks for making that point. So, John, let's get back to the physical activity part of this. And I'd like to talk to you about body composition. So as these medications allow more and more people to lose 20% or even more of their body weight in some cases, what is the impact on body composition, especially in lean body mass? And for the benefit of our listeners, can you define what body composition is and talk about lean and muscle mass?
Yeah, sure. So, body composition can be measured in a lot of different ways. Some are more sophisticated than others. Some are more accurate than others, obviously. But, we basically break the body into a variety of components, the adipose tissue or the fat tissue. And then we have the lean components. And the lean components are made up of the muscle. They're made up of the other lean components like organ tissue, connective tissue. And then, of course, we have bone that comes into this as well. So those are kind of the big things. And, you know, I think that everybody on this panel would agree that the ultimate goal is to kind of maximize the adipose tissue loss. That's the real thing that we want to be reducing. But with any weight loss, we've seen lean body mass be reduced. And the one thing I want to point out to everyone is lean body mass is not solely skeletal muscle. And so when people say, well, I've lost weight and I've lost all this muscle, there are very few, if any, trials, especially in these with these medications, to know that have been published, to know how much of the lean loss is muscle versus how much of it is other stuff. And we've shown in non-pharmaceutical trials that some of the lean tissue you lose is, for example, your cardiac tissue, your left ventricle. So we can't attribute all the loss to skeletal muscle. So the concern sometimes is that we're seeing a more of a lean mass loss, which may be a little more muscle mass loss with these medications. We don't know the real impact of that. Clearly, I think everybody on this panel would agree that if you lose more muscle mass, that's going to affect things like insulin sensitivity. That's going to affect function. But I want to caution everybody just a little bit, because we did studies, Kelly, as you probably know, 30 years ago with very low calorie diets, where we were getting the same magnitudes of weight loss in 6 months. And we saw these losses of lean tissue. But with exercise, when you added exercise to it, strength still went up, fitness still went up. We still saw the improvements with these types of exercise. And so exercise can still have a benefit. So I really think it's not, the other part I want to really emphasize here is we're so wound up about the volume of the tissue. How much do you have? And the reality is patients with obesity actually have more lean mass and likely more muscle mass than their leaner counterparts. Yet they're not as strong, yet they're not as fit. So it's really not about the volume of the tissue. We're trying to shift the conversation to the quality of the tissue. What's the quality of the muscle that you have that remains? Make that the focus, not retention of all of the lean mass. And I think that this is a critical discussion for us around body composition and how physical activity and exercise fit into this paradigm.
So that's a really very helpful description of the process that goes on. So let's talk about age, if you would. So as people grow older, how do you think differently about the loss of lean body mass? Is it especially important in older people, and what can people do to maintain their lean mass? And also, are there differences for men and women in this?
Well, the literature now is pretty interesting that women tend to be doing a bit better on these medications than men. They're losing a little more weight. And with age, there's obviously the age declines in muscle or lean tissue that are kind of a naturally occurring thing that occurs. We're trying to not promote more of that. What's interesting about most of the trials, though, Kelly, is most of the trials don't have a lot of people in the older age groups. And even those that don't report on the body composition changes. And so I think the work has to be done in this space to really understand, the life course of the change in body composition, not just is it changing the same for everyone. But I think that when you start to think about lean mass, as was mentioned earlier, well, maybe resistance training can help with that. But I think again, we're not going to, while we're on these medications, we're not going to be building volumes of lean mass. In fact, I'm not sure we want to build volumes of lean mass. I think what we want to do is make the tissue we have stronger. So yes, resistance training can help. There's a challenge with that, Kelly, and I think as a psychologist, you can appreciate this. How do you help people to engage in that resistance training? Not everybody can go to the gym. Not everybody has access. And in fact, we've done some work here with my colleague, Renee Rogers, that have found that people who are on these medications are also reporting, fatigue. They're reporting fatigability. And so how do you help a person who's fatiguing to now engage in an activity that requires them not to fatigue? So we have some additional unique challenges. The other thing I also just don't want to dismiss, Kelly, and I think it's critical. We can still improve the quality of the lean tissue and the muscle that we have with simple activities like people going to take a walk. Mm-hmm. They can go and take a walk, and that's easy for people to do. And we've seen that. We aren't going to detect it with our typical body composition measures, but when we had people go take a walk who had bariatric surgery, when we delved in and did a muscle biopsy on them, the quality of the muscle improved just by going to take a walk. So I think we have to be very careful about how we think about activity. And my colleague has said, it's if we treat exercise as one size fits all, that's actually going to translate into one size fits none. Because everyone has to be handled in a slightly different way, just like we do on the diet side, just like we're titrating the medications.
Well, John, let me ask a follow-up question. It's very affirming what you said, that a lot can be accomplished through physical activity with respect to maintaining and improving the quality of your lean body mass. And since you said, not everybody can afford or has the time to get a gym membership, there are things like walking that can be really very helpful. And you mentioned resistance training. So there are some things people can do at home, I'm assuming, with, using exercise resistance bands or weights or things like that. How would you recommend people find out about what they can do at home?
Yeah, well, I think that there are some options with that, Kelly. And, of course, everybody's going to say, well, go out and do an online search and find something. That's hit and miss in many ways. But there are some very credible resources, some of which can be made available through organizations like the American College of Sports Medicine and others that are very credible. And also, I would actually advocate that all the care teams should have access to a clinical exercise physiologist who knows how to work with patients with obesity and chronic conditions, at least as a resource to point things in the right direction. And, we're trying to build some of those resources here that can be made more broadly available. But I think don't want to do is make this complex. Exercise, people that have had obesity, and we've talked to them and we've done work in talking to them, they've had a lot of bad experiences about exercise because a personal trainer says you've got to train like an athlete. You've got to do these things. And I think we really want to be careful about pushing an agenda on everyone and make it patient-focused, not system-focused in terms of how we handle the exercise. We have a golden opportunity to rethink activity with these patients. I think we want to make sure we don't mess that opportunity up.
So thanks. And also thanks for mentioning the American College of Sports Medicine as a possible resource. It's a terrific organization, has been working in this on these topics for years and years and years. And I've always found it a very trustworthy source of information. So Lisa, how important is nutrition in this? It's obviously important, but just like with the physical activity, you could say, okay, the drug takes away the need to be physically active. John's shown that's not true. So what about proper nutrition as people are reducing their calories? It seems like it's more important than ever.
Well, it is. I mean, healthy eating's always been important, but when we have smaller portions, it's even more important that our food choices are good, because we still need to meet our nutritional needs, and we're doing it with smaller amounts of food. So, and I actually want to just mention and thank John for bringing up fatigue. And so for many years, I worked with patients like Lorena, patients who'd had bariatric surgery. And when I used to hear as a clinician someone reporting fatigue, it actually would tell me a few things, because it's not an intended effect of medications for weight loss or even bariatric surgery, but instead might be a sign or a symptom that something is wrong. So for example, a common thing that can cause fatigue is inadequate fluid intake, inadequate protein intake, or even a vitamin or mineral deficiency. And so patients shouldn't accept fatigue as, oh, I hear everybody gets this. That's another symptom, like those gastrointestinal adverse effects that we've talked about before, that really should be brought to a doctor. Now, I think, the other piece about nutrition, and which we covered in the Nutrition Review article, which was intended for primary care doctors, is really, it's really important to focus on certain nutrients when we're losing weight. And in particular, I mentioned already protein and how important that is. John has mentioned the role of exercise, and there's a complementary role when you get adequate protein and adequate physical activity. This can help a person avoid or may help them avoid excessive loss of muscle and weakness during weight loss. So critical for protein intake. Things like fiber are really important. The vitamins and minerals are really important. And we just, if we have smaller portions, it's going to be harder for us to get all of those. So we have to be more careful about our choices. So that means, like always, it's got to be a focus on those nutrient-rich foods like lean proteins, like vegetables, fruits, and whole grain foods. Same as is recommended for every American. These are all, the nutrients that we're talking about are really important for so many body processes, including energy production. So if we don't get the nutrients, we may feel fatigued. But they're also important for things like our immune function and our skin health and our bone health and so many other things. It really covers our whole body. So important.
So, Lorena, let's dig in a little deeper on this. Lisa has really created a nice picture of how important nutrition is. So what sort of things do you recommend to people? What sort of dietary advice do you provide? And how do you think about the balance of things like fiber and protein, et cetera?
Lisa, I could just hug you. I just love what you said. And that means that, and that's the reason why I think that the role of the registered dietitian nutritionist is vital when it comes to anti-obesity medications, and not because it really does help the patient to actually be successful in the road to health and achieving optimal health. I just want to say something that affects every single American, and that is that according to the dietary guidelines for American, when it comes to dietary fiber, vitamin D, iron, calcium, and potassium, those are the nutrients of public health concern. That is, that they are not consumed in the American diet overall, whether we have diabetes or not. And fewer than 5% of all of us adults consume the recommended dietary allowances for fiber. And that is one of the side effects, potential side effects of persons that use anti-obesity medications is constipation. So this can be resolved by increasing fiber, which is already a nutrient that is underconsumed. And persons with obesity consume even less. So what are some of the foods that have dietary fiber that can be beneficial for all of us, including persons on anti-obesity medications? Well, I can say that evidence-based research shows that kiwis can really help with constipation. And kiwis are a fruit that can also is an antioxidant. We have prunes, for example, that can also help. We have beans, legumes, and peas that can contribute that protein, that plant protein that Lisa was talking about, and can also help with to reduce the postprandial effect in persons with diabetes. So we're talking about plant foods that are high in dietary fiber. So that is at least one groups of fruits and vegetables that are healthy that can also help to mitigate constipation. So we are talking also about oats, which is a healthy carbohydrate. We are talking about cereals that are high in fiber. And so we are thinking here in terms of foods that can also help. One concern that I have, and that is how to pack meals that are both healthy and that can contain protein. And that is because of the need to also be helpful in reducing sarcopenia, which is minimize muscle loss, as John was alluding to. And that is to have enough protein. One of the recommendations is to have zero 0.8 to 1.2 grams of protein per kilogram of body weight. So just to simplify that, let's say 1 gram per kilogram of body weight. So one person that weighs 200 pounds, that would be roughly 90 kilos. The recommendation would be to consume 90 grams of protein per day. Where would they find that? Well, they would find that if they want to choose plant protein, that would be soy products like tofu, edamame. They could find that in seafood, lean meats, and poultry. Or if they do not feel hungry, another suggestion that I make is have meal replacement protein shakes that can have about 15 to 20 grams of protein servings. That will be the last resort. Or having low-fat dairy foods like yogurt, and then pack other things with it so that in a small meal, you could have your servings of protein foods. What are as a dietitian, some of the signs and symptoms of a protein deficiency? Well, it could be weakness, just like Lisa was mentioning. If they feel tired, sometimes they could say, I have hair loss, or some of the skin changes. In carbohydrate, I focus on whole grains. It could be oats, it could be barley, it could be whole wheat, fruits, vegetables, and foods that can provide them with the fiber that they actually need. And then when it comes to fats, I focus on the fats that are heart healthy. That means the avocados, that means nuts and seeds. It could be walnuts, it could be almonds, pistachios, and olive oil. Those are the fats that could be used in moderation. And what I say is, even when you're not hungry, small meals throughout the day, and then remember your fluids. Sometimes that fatigue could be that they may be dehydrated.
Thanks. But a lot of really helpful practical advice. So I appreciate that. You know, just to put this all in context, if somebody's listening and thinking about using the medications, they might say, oh my God, I've got to see an exercise person and a nutrition person and a physician, and I've got all this stuff to think about. But actually, it's all pretty straightforward, isn't it? If you use some sort of common sense in being physically active, and you use common sense with nutrition, and pretty much eat a diet that you'd want to be eating anyway, you're going to accomplish a lot of what there is to accomplish. And then the extra stuff you can learn, and then you've got it, and you don't have to worry. Then you just sort of know what to do. And so it's probably not as daunting as people might think, and that most of the advice is fairly straightforward at the end of the day. And John, I'd like to, speaking of that, I'd like to have you help us put the exercise in a little bit of context. So you made it very clear why exercise in physical activity is so important, but how do people get motivated to do it? And how do they think about what kind of a program would be most beneficial?
Yeah, I think, Kelly, it depends on the outcome you want, is the program that you want, right? But I think that we don't want to over medicalize this. We don't want to over complicate it, like you're saying. Not everybody that needs to start or wants to start an activity program needs to go and get a stress test done, needs to get an extensive workup. I think, I like to say when you go to see your doctor, unless your doctor told you not to be active, you walk from your car into your doctor's office and you walk back. I want you to just do a little bit more of that. That's the kind of thing. And I think, Kelly, you remember some of the early work that I did in my career where we said, listen, once in the morning, once in the early afternoon, and once in the evening, go out and take a 5 to 10 minute walk. Just get out there and do 5 to 10 minutes. And that way time's not the barrier. And what we found when that happened is once people got out and got moving, it went from 10 minutes to 15 minutes to 17 minutes to 20. So I think we want to make it very simple. How do you think about just getting up and moving? And if you're a person who has mobility limitations, which many patients with obesity will have that, we understand that. But there are a lot of other things you can do in the chair, in a seated position, where you're doing 5 to 10 minutes over every few hours of doing something and building it into that. If you need something more extensive than that, then you might need a little bit more help. But let's not overcomplicate this process.
Thanks. That's very helpful.
If I could, I want to just jump in. From my clinical experience, listening to this, I could expect that there might be patients out there who say, "All right, so you're talking about healthy eating and physical activity, and I've done that. I've done that for years, and it's been a challenge, or it hasn't, and I'm doing it." And I think one thing that's different when we're talking about obesity treatment, the medications like tirzepatide or semaglutide, or even with treatments like bariatric surgery. The treatment actually enables people to have a healthier lifestyle. So what might have been a big struggle before to make those healthier choices, what I see in clinic is that it's a much easier choice for patients if they're not as hungry and they're more full, and they may have less cravings or thoughts about food that are driving some of the emotional eating that Lorena was talking about earlier. And in the same vein, I think I've had lots of patients over the years who did have mobility issues related to their excess weight. And once they're able to get some of the weight off, their mobility can increase. And we know from the clinical trials of semaglutide and tirzepatide that on average, people's quality of life increases or improves. And for people who have physical function limitations at baseline, that can improve with treatment as a result of the weight loss that they experience.
Yeah, and Lisa, I can jump in too real quickly, Kelly, on this. And we've seen that as well. The one thing I will say is that when we work with patients with obesity who've got bariatric surgery, and even some of the patients who now we know are getting the medications, we find that from a physical functioning perspective, the weight loss helps them to be able to move more. But that's not translating into them moving more in a lot of cases. And so I still think we need to help them to understand that it doesn't have to be complex. So I agree with you. I still think we need to help to make sure they understand that the barrier doesn't have to be what it has been.
Okay, that sounds good. Now, at the top of the hour, I'd like to turn our attention to audience questions. And I still got several things more to ask of our three panelists. So I'm hoping these next few questions, you can keep your answers to like 30 seconds or so, even though I know they're complicated questions, but let's give it a shot. So the first one I'd like to ask is about how people respond psychologically to the use of these drugs. So as people are using these drugs, and they're losing weight and their lives are changing in important ways, what sort of psychological and social things do you see occurring? And Lorena, let's start with you. And again, let's keep it to 30 seconds if you can.
That there is a lot of misinformation that they hear, and sometimes they may not know how to respond to the information that they are getting, especially about when to stop the medication or if they are going to continue with the medication forever. And they don't know how to navigate that. So that is very challenging for them. So what I do advise is that they seek the healthcare professional to receive an answer, and not just what they read or what other people tell them. That's my answer to them.
Okay, thanks. Lisa, let's go to you.
Yeah, so I first want to step back and say, I think there's some changes in our society that hopefully will help support patients in a weight loss journey. And so, for example, weight bias and weight stigma is incredibly prevalent in our society, and it can have a real negative impact on patients, including increasing the risk of depression and anxiety and disordered eating and low physical activity levels. A whole host of things can even trigger a stress response in the body, leading to increased blood pressure and blood sugar. And so I think that now that we have more effective treatments and a greater awareness that obesity is a chronic disease, hopefully this will translate for patients to be able to have less shame and blame around their weight over time. With treatment, and this is true for bariatric surgery as well as the newer medications like tirzepatide and semaglutide, I mentioned that generally quality of life improves. However, for some individual patients, they may experience changes in their mood or in their relationships with others due to the weight loss that they've experienced. So, a perfect example would be patients who have had an experience of trauma or abuse. When they lose weight, they may feel very uncomfortable by the increased attention to their body that might happen as a result. And so, if that's happening for members of the audience, if they're feeling uncomfortable or they're having changes in their mood, again, this is another opportunity to reach out to a doctor or a mental health professional for support. And it's important to know you're not alone. Obesity is a difficult disease, and it's created a lot of burdens and barriers for care for people for many years. I think we're just starting to see improvements in that.
Okay, John, would you like to add anything?
Nothing major, Kelly, other than I think that has been said. There's a lot of input coming in for patients before they've gotten treatment and now they've gotten treatment, and understand there's a lot there. And all I would encourage patients to understand is it's a journey. It's a journey, and it's what's working today, it's going to keep working tomorrow. But it's a journey, just like we've all been on. And if you have a struggle today, that's okay. You restart tomorrow. So we've all had these ups and downs. I think the difference between those who really stick with it and those is when you have a tough time, you keep on that journey, as opposed to saying, see, I told you this wouldn't work. And put out the noise from the people who say you don't need this. There's a reason that this is helping. And so stay on that journey.
Thanks. Lisa, I'd like to ask you very quickly about stigma and bias. And I know Lily is doing work on that. Why are these things important? And if you could just give us a quick sense of that, that would be great.
Yeah, no, I really appreciate the question and the opportunity to focus. So I mentioned that I've been, I've had the privilege of treating patients for over 20 years. And I'm really, I've had the opportunity to see how much weight bias exists. It exists in all spheres of our life. So it exists in healthcare, unfortunately. It is present in school and work. It is present in our family interactions. It's even present in public places. So patients have told me horrible stories about what happens to them when they walk down the street, on the sidewalk, or in grocery stores, that people may feel at liberty to talk about their choices. And so it is really important that we recognize and we call out when weight bias is happening, because it's only with this recognition that we can actually address it and make it better. I do think, as I mentioned, that this greater understanding of obesity as a chronic disease, and in particular, this understanding that there are complex biological systems that influence our appetite and our eating behaviors and our body weight, that we might feel we're in total control, but in fact, there are lots of hormones and systems that are influencing all of these things. And so patients don't have to feel the shame and blame that they've felt for so long around weight. And I'm just really proud. Lily has done a lot of work on that, because we recognize how important it is. And patients with obesity really deserve the same level of care that anyone else deserves for any other chronic disease.
Thanks. It's really helpful to hear you talk about that, because that work is so important, and so many people's lives are affected by the stigma and bias. It's really great that people are paying attention to it. I might also mention that the diaTribe Foundation has done really good work on this topic, and there's information available on their website about bias and stigma with respect to both obesity and diabetes. Lorena, could you just tell us quickly, what are you seeing about people getting insurance coverage for these medications?
Yeah, sometimes it is difficult to obtain insurance coverage. So I am going to share some information, and I want to credit what I have learned. I have learned from my colleague Diana Isaacs, who is a pharmacist and certified diabetes care and education specialist. And one thing that she has emphasized is to obtain the prior authorization letter, which is a prerequisite for many medications. And sometimes even obtaining the prior authorization letter with that, it may not be approved. So after that, what is needed is to appeal the decision. Once the patient receives the denial, then the next step will be the appeal letter. There are two different levels of appeal. There is an internal appeal, and then there is an external appeal. What Diana emphasizes is that there needs to be information that it's required. Well, the first step, of course, is the required step, which is the information about the patient. But what is most important is the documentation about the need for the medication, which is indicate what is the reason, and to have that documentation in the patient's chart. For example, whether the patient has insulin resistance, whether the patient has lived with overweight, obesity, and also what the benefits are, which is reduction in hemoglobin A1C, body weight, whether the patient has uses insulin, whether insulin, there have been changes, etc. And that has to be sent to the company to help with insulin coverage. So that's some of the things that can help patients to obtain coverage.
Thanks. That's a big help. So this is a great time for us to turn our attention to some questions from the people who are listening in. And there's one I think that really is very important, and really anybody could answer this, but people are asking questions about stopping the medications and regaining the weight. What happens with that? And how should people think about using these drugs over time? Should they gradually increase their dose? Should they be cautious about stopping the drug? How should people think about that? Lisa, I'd love to hear what you say about that.
Yeah, this is a great question, and it's certainly one that patients of mine have had over many years. When we understand that obesity is a chronic disease, we can understand that its treatment would be similar to other chronic diseases. So, for example, if a person has high blood pressure and they're started on a medication for high blood pressure, they don't expect to stop that medicine in a year or two once their blood pressure is better. Because if you do that, then if you stop it, your blood pressure goes back up. Same thing for diabetes. And I think most of the audience, probably those with type 2 diabetes, recognize that once you get your A1C under control, it's not time to stop the medicine. It actually is a sign that the medicine is working. And if we're talking about weight management medications like tirzepatide or semaglutide, we are thinking about them in much the same way, so that if patients are having a good benefit of the medication in terms of weight, hunger, and fullness, and for people with type 2 diabetes, if there's also improvement in their blood sugars, then as long as their doctor agrees, there wouldn't necessarily be any reason to stop the medication. Now, people sometimes say, oh, well, then it's a forever medicine. forever is a really long time. And I think, there are so many advances that are coming, and we don't know what the future will hold. But what I think is, we know that obesity is a chronic disease requiring chronic treatment. What that means, 5 or 10 years from now, we'll have to wait and see what the research shows.
So, Lisa, another question I think that's probably a good one for you to address is somebody asked, how do you find a good doctor to help with these issues?
Yeah. This is always a challenge that, all clinicians nowadays are so busy, and it may be hard to find the right person. As a patient, it's always hard to know. There are a few options. The American Board of Obesity Medicine, for example, has a certification exam that physicians can take that can help them demonstrate that they have a level of sufficiency and fluency in treating people with obesity. And so you can look for that. You can go to the American Board of Obesity Medicine website and look up a clinician in your area. And that may be one really nice opportunity.
Okay, thanks. John, a question for you is somebody asked about what about people that have limited access to the opportunity to be active, like they don't live in a place that's conducive to walking, or say people with disabilities. How do you think about being physically active in those cases?
Yeah, well, I think the first thing I'd like to say is I think that we all need to be advocating, just like Kelly, you've done for years, advocating for healthier nutrition and food sources. I think we all have to be advocating to make sure that resources are available for patients with obesity to engage in physical activity. And that could be as simple as making sure that cities keep their sidewalks in good shape so patients can walk. So I think this goes beyond what's happening in the healthcare sector, but it goes to the public sector as well, and advocate for that. I think, though, there's a couple of things you can do. And of course, these are simple answers, but, we did a study a number of years ago now where, we all watch television from time to time, and we're all clicking. When we get to the commercial, we go to another channel. We actually have done things where, when the commercial comes on, instead of clicking to another channel, get up and walk in place. We've also done things where you have prompts within a TV show whenever you hear a certain character say a certain line, you get up and walk in place for a minute. So you can do it in the confines of your own home while still doing the other thing. So similar kind of environmental things you can do. And I agree, there are a lot of patients with physical limitations or disabilities, and those patients need activity as well. There's a lot of what we call chair-based activities that have really been designed for mostly older adults, but could easily be adapted to patients with these limitations to actually start to get them on an activity regimen that could do the same thing. So again, the resources are there, and I would encourage you to ask your physician, who should probably be able to at least point you to something that could help you in that way.
Thanks. I had this picture in my head. There's so many commercials when one watches TV. If you get up and did a little walking in place, you'd be a superhero in no time at all. But it's a very practical bit of advice you have. Lorena, a question for you. Are you seeing any nutrient deficiencies in people who have been using the medications over the long term?
Not precisely. However, it is a good idea to check for, there could be some micronutrient deficiencies in certain individuals. Like I had mentioned before, there are some already under consumed nutrients of concern for all individuals. So when there is a decrease in consumption of food over time, there could be a deficiency of vitamin D. So I would certainly recommend for physicians to test for vitamin D. That would certainly be one of them. And especially if you are living in certain parts of the country in which during winter time, there is less exposure to the sun. And a lot of people are deficient in vitamin D. That would be one. The other one would be vitamin B12. That may be another one. And that is because vitamin B12 absorption, it can be reduced when there is reduced stomach acid production and slow gastric emptying. So there might be a slight increase in vitamin B12 deficiency. In addition to that, when individuals with type 2 diabetes are taking metformin for many years, there may also be a vitamin B12 deficiency. So that is another vitamin that it may be a good idea to check to see if there is a vitamin B12 deficiency. So those are probably two vitamins that I would probably check. It is a good idea. Again, calcium, vitamin D, those are good, the mineral to also make sure that you're having good consumption of that. But I would probably recommend more to increase the foods that have calcium in it. And I had mentioned before the dietary fiber.
Good. Thank you so much. So I'd like to end by asking each of our three panelists kind of a fundamental question about what do you think the future holds? Are you optimistic? And as you peer into your crystal ball, what do you see in the future with respect to these issues we've been talking about today? And John, I'd like to start with you.
I think the future is actually very bright, Kelly. Been doing this a long time as well, and this is a paradigm shift for us. And I think we have the opportunity to embrace it. And I like to talk about the treatment of obesity the same way I would talk about training for a marathon. We could all go out and run. We could all have the right trainer. We could all live in the right environment, but not all of us are going to set the world record. Very few are going to set the world record in the marathon because there's this biology behind that adds to that variability. And I think we're at the point where we now have acceptance that there is a clear biology behind the obesity that is interacting with our environment and our behaviors. And so I think because of that, we have a paradigm shift, not just in the treatments available, but as you said earlier, how we can start to we can now think about healthy eating because the food noise is being addressed. We can now start thinking about how healthy active lifestyles in the same domain. So I think that we need to embrace this opportunity and go forward with it in a way that we have not been able to do in the past. And it's paradigm shifting for all of us. I think we should just embrace it. But I think the future is very bright.
Good. I love the optimistic note. Lorena, what about you?
I also feel very optimistic as well. I think that I find that the anti-obesity medications are going beyond just the weight, especially when I see that it can improve also the cardiometabolic health of persons with diabetes. I think that we are fine-tuning how we can better help individuals to keep them healthy and finding the right dose of the medication so that they can learn to enjoy food as well as to manage their weight. And like John said, to find the right exercise that accommodates their life, as well as the right food for them. And also that we are working in a multidisciplinary manner that help us, all of us, help the patient, the person with diabetes to achieve joy as well as good and optimal health. And I see also that it's going to continue to evolve. So I'm looking for that. I'm looking for that moment that it evolves in a much better way.
Thank you. And Lisa?
So first I want to again thank you and the wonderful panel here for this great discussion, and to thank also all the people who've tuned in to listen to us. I have, as I've mentioned, been around for a long time and having the privilege to treat many patients with obesity and diabetes over the years. And I too am extremely optimistic for the future. I think this evolution in our understanding, the recognition of obesity as a disease, and the biology, as John was speaking about, that really drives appetite, eating behaviors, and body weight, really can help to reduce a lot of the shame and blame that patients are currently burdened with unfairly. And for the future, I really expect to see that there's going to be an increasing array of treatment options. And this is good news, I think, because it will lead to more personalization of care. And importantly, as Lorena was saying, the goal here is really to optimize health, optimize outcomes for patients. And I really think that we're on track to do that. So thank you.
Well, and thanks to each of you. Boy, what a wonderful webinar this has been. The All-Star team took the field and performed like the All-Stars we expected. These are complicated topics, and you all explain things very clearly and in a very hopeful way, which I think is nice. And so this seismic shift that we talked about, I hope is more clearly explained to people because of the webinar, and I hope that individuals came away with a much more thorough understanding of what these medications can do and what impacts they can have on people. So thank you all again for taking part. It was really wonderful having you join us. I'd like to also thank diaTribe and the sponsors that make these free Musing events possible. And thanks to everyone in the audience for taking the time to participate in this really pretty amazing event. The platform will remain open for the next 30 minutes, so you can take part in the community networking feature. Just click on the networking icon on the far left of your screen. Again, that's the networking icon on the far left of your screen, and you'll be randomly joined in conversation with another person who's online. And then you can move on from there to meet other people. And thank you all again for taking part, and enjoy the rest of your day.